Whether I can start.
Shall I start?
Navita?
Okay. Very good afternoon to everyone, and welcome to the seventh session of MEPMR academic program, monthly academic program. Today we have with us Dr. Nitin Menon, who is a consultant in neuro rehab, PD Hinduja Hospital, and a lead consultant rehab medicine in Apollo Hospitals, Navi Mumbai. And he has more than 25 publications. Because we won't be wasting the time. This time the time has changed. So I would just quickly say Dr. Abhishek, our chair, to say a few words, and then we can start off.
I think it's a good initiative. We are doing quite good in last 6, 7 months, spreading knowledge among our colleagues. And today we have a good topic to discuss about neck pain. Nathan, please go ahead.
Thank you, sir. Thank you, ma'am. So I'll start. Sorry, it's done. Is it start? Okay. Let's see. Okay. I hope everybody can see this. So let me begin. So what I want to emphasize in today's talk is, see, everybody has recourse to textbooks in medicine and rehab medicine and pain medicine and all of that. So you can see a lot of stuff about neck pain and you can read about it. So we are not going to actually, go into the nitty-gritties. I want you to learn how to think about neck pain, what is the evidence which is currently available for managing neck pain, how do we evaluate neck pain, how do we make categories of patients in our mind, and then how do we manage these patients, and then some of the questions that may be asked to you when you are with a patient. The questions might come in your mind, or sometimes the patient might put those questions in your mind, and some scenarios that we see in our day-to-day practice. I don't work in a medical college, so we see things slightly differently as compared to what you would see in a medical college. But the talk is just made in such a way that it addresses everybody's concerns. If there's anything else, we can address it at the Q&A session. So let me begin now. So colloquially, it's called as cervicalgia. People use this term because neck pain is a very, very broad term. It encompasses a lot of uh, sub entities within it, so it's just broadly called as that. So it can be any part of the neck, sometimes right up to the shoulder, the arms, anywhere, and you can have sometimes back of the head as well. So all of this can be considered as neck pain or pain arising from the neck. uh, it can be of short duration, of intermediate duration, and of long duration as well. We will be consistent. We'll be focusing a lot on the longer duration of pain and not so much on the shorter duration, because those uh, the, the management of that is not as complex as what you would see in the longer duration of pain. So this is just the statistics. India is somewhere in the middle, or maybe the less incidence of neck pain is what we are seeing. It's more in the developed countries. It might just be a statistical anomaly. I don't think that probably we are collecting statistics the way we should be collecting, and that's the reason we are. Otherwise, there is no dearth of neck pain patients in day-to-day practice anywhere in this country. Neck pain typically is seen more in the middle age. Say it rises from somewhere in the mid 30s to about the 60s, and then tends to taper off just because of life expectancy. It's not so much in the younger age group. Uh, this is an interesting slide. So what these people have said is that they have done a population-based study, and they have found that the neck pain in future, South Asia, where India lies, and Africa, these are the areas where neck pain is going to grow a large number, partly because of population's growth and partly because of better access to services. And in traditional countries like Europe and US, it might become lesser. So let's see how it goes. But since all health conditions are increasing in India, this is not a surprising bit of news for us, but something that we should be prepared about. The neck is, if you look at the anatomical um, uh, factors that we have to take into consideration. The neck is the area which is above the the topmost area of the spine, which lies directly under the skull, composed of 7 vertebrae, of which the first 2 are named. And they are atypical vertebra, 3 to 6 are typical, and 7 is a slightly modified typical vertebra. All of you know the construction of the vertebra, how it looks. It has a bifid spine. The first vertebra has no spine at all. It is a circular ring which supports the occiput. And the second vertebra is where a lot of movement of the neck happens, and especially the rotation movement. The first is where the nodding movement happens, and then a lot of flexion, extension, and lateral rotation happen at the lower cervical vertebra. The cervical vertebra are also characterized by 2 things. One is that the the transverse foramen, where which has the passage for the vertebral artery, and the uncinate process, which is an articulation between 2 vertebra, apart from the facet joint as well, which allows a large range of motion. The maximum range of motion in the spine is in the cervical vertebra because of this. The pain generators are, these are the disc, the bone, the joints, ligaments, muscles, and the nerves are the pain generators. This is common for all vertebrae. These are the common pain generators which are normally seen, and these are the things that we try to target with our interventions. There are a number of risk factors which are which can give rise to neck pain. Some of them are psychological, as we have seen: stress, anxiety, poor sleep, catastrophizing, personality behavior disorders. Those kind of things can give rise to any chronic painful condition. Neck pain is no exception. And musculoskeletal problems like degenerated disc, disc herniation, nerve root compromise, foraminal narrowing, uh, spondylophytes, osteophytes, those kind of things. Some autoimmune diseases, especially rheumatoid arthritis, can give rise to neck pain and instability, especially in the upper cervical region. Same thing with genetic as well. It's more common among women and more common in the middle age and the later part of life as compared to the earlier part of life. The most common symptoms that the patient will complain is of pain in the neck, limited motion, pain radiating to other parts like the arm, the back of the head, the shoulder, the mid back and the lower back. Sometimes patients can come with headache, loss of motion in the cervical spine, stiffness in the shoulder or the spine. Um, it can be sharp, it can be dull aching, it can be tingling, it can be neuropathic, it can be a mix of all of these. So these are the traditional symptoms that anybody would come to a physician for addressal. But there are some other vague symptoms as well, which the patient can come to. So sometimes sudden fainting episodes, fullness in the ear, uh, difficulty with swallowing, pain in the neck after a vehicular accident where somebody rear ends a car, pain in the jaw, pain while eating, while chewing food, dizziness, headaches. We've seen the whole walking difficulties, whole list of symptoms. All of these are sometimes attributed to the cervical spine, and you can find them going to various specialists and getting a cervical spine MRI or an X-ray, and then being referred to you saying that this is probably originating from the cervical spine and we need you to address this condition. Uh, Typically, the pain or any kind of chronic pain is, or even for that matter, acute pain is classified as nociceptic and neuropathic. And now with the new definition of pain, the nociplastic pain has also started appearing in uh, some of the studies. uh, so if you see what is nociceptive pain, it is basically pain with which will be which you will see with some kind of movement, with uh, some kind of findings which suggest a localized response. Uh, you will see that the patient the person complains that the pain becomes worse with movement. The pain becomes is worse either in the morning or in the later part of the day. There are some kind of inflammatory markers which might come positive, like a CRP or an ESR, and you can see that some pain might be reproduced by some movement, some kind of examination finding like movement or tenderness at that point. Most of these pains are nociceptive. Nociplastic pain is generally with chronic pain itself, and you can have a pain which is vaguely distributed. It does not conform to any nerve root distribution, and you might have some findings like pressure point tenderness. So the patient might jump if you just apply a little bit of pressure to the pain. The patient can have hypersensitivity phenomenon like allodynia, and this, though these are all classically described for neuropathic, but there is somewhat of an overlap, and you will find a lot of psychological problems with these patients. They do have history of other pain. So if you ask them, apart from your neck, does other areas have pain, and then they might you will find very often that they give you answers that yes, my other areas of the body also pain. They might have inordinate amount of tiredness, inability to work, increased sensitivity to light and sound, sleep problems, cognitive problems. So these are not typically just the pain arising from a sensitization of a nerve receptor, but there is some amount of peripheral or central sensitization which is also happening. And neuropathic pain is obviously a pain which arises because of irritation of a nervous tissue, and then you will find some amount of signs and symptoms which are corresponding to that. So the pain is in a discrete nerve distribution. You might find some reflexes or some sensory loss or some sensory dysesthesias, maybe some motor signs as well to correspond to it. So broadly, these are the three categories. It's a good idea to kind of categorize the patient when you come when the patient comes to you, to ask these questions and see whether you're dealing with which kind of pain that you're dealing with. Some of your pharmacological interventions or your other interventions might depend on how well you can classify these kind of patients. So that's number one. The second kind of classification that we can do is divide the pain into axial and radicular pain. So axial pain is basically pain which arises from the axis or from the midline of the cervical spine, and it is generally it doesn't radiate very far off. So even if it radiates, it will radiate to nearby areas, and you can have the facet joint being involved, you can have the disc being involved, or you can have the muscles and the ligaments being involved. So we'll discuss a little bit on facet pain later on, but the pain with disc is generally you get a more of a flexion maneuver, which gives rise to more pain because flexion tends to increase the intradiscal pressure. Whereas the muscles and the ligaments are present more in the posterior side, though there are anterior muscles also which can give rise to tenderness and provocative pain when you stress them, but more of the time you will see them happening posteriorly. And you can see loss of range of motion in any plane where the muscle is supposed to carry out the movement. So if, for example, you have a trapezius which is tight, you might find patients who have problems with rotation and with lateral bending. Um, Most of the times you don't require any imaging if there is no other finding, but no other examination finding to tell you that there is something serious. But sometimes people do ask for plain film images and sometimes MRIs as well. No further testing is involved, and you can just proceed straight to treatment. In contrast, radicular pain is, of course, when there is a compression of a neural tissue. That neural tissue might be compressed because of a herniated disc. It can be because of stenosis, because of cervical spondylitis, and the patient can present acutely, subacutely, or have a chronic presentation. And like I said, you might find some neurological findings, some form of sensory. So if you compare both the sides, you might find some sensory reduction, some reflexes which might be less brisk than on the other side, or maybe some mild motor weakness. There are some certain examination findings, some provocative tests. We will discuss that in the coming slides. And most of the times, an MRI is required to settle the diagnosis. Occasionally, people do opt for electromyography as well. Spinal stenosis is generally a disease of older people, so you will very seldom see it in younger patients. You will see it after 55, 60, and those kind of patients. Sometimes you can have a patient who has a trivial trauma and which kind of leads to a significant spinal stenosis and maybe very significant neurological findings as well, which can lead to cervical myelopathy. You can have cervical myelopathy, which starts insidiously as well, and without any trauma, the patient presents with neurological findings and some amount of MRI which shows signal changes in the cord. And the treatment really depends on how acute the condition is. With chronic condition, obviously, the role of surgery diminishes. If it's acute, some amount of decompression might help the patient. These are the uncommon causes. So you very rarely, most of your patients will fall in the former category. Very rarely you will find patients in this category as well. You need to ask very pointed questions to rule out any one of these. Missing this is not good, because if you don't pick this up in time, the patient can land with a lot of adverse outcomes. And one of the important things for a physician to know when he or she is dealing with neck pain is to see that we are able to find or pick up these uncommon causes very, very fast. And I still remember when I was a resident, we had a patient who presented with a Lermit sign, which has a very good sense, very large specificity for cord involvement or upper cord involvement for that matter. And when we imaged his MRI, I mean, we got an MRI done, we had to get an urgent MRI done for him. And we saw it showed an imminent atlantoaxial subluxation. And the patient was referred fast to neurosurgery. They did a fixation, and the patient had very good outcomes. There was nothing, no neurological deficit at all. So it's very important that when we sit in our OPDs, we look for all of these. You can have tumors, you can have infections, you can have inflammatory pathologies, AV malformations, and neurological problems, like I said. We need to find out. There have been many reports of people treating Guillain-Barré syndrome patients initially as radiculopathy pain. And then when they start developing motor weakness is when they find out that this is actually a Guillain-Barré syndrome. So this is not very uncommon. Please be on the lookout and ask very pointed questions as to if to rule out any of these conditions. So like I said, facet pain can be both acute and chronic. So acute uh, pain is generally, you don't simply have a facet pain. You will have a lot of muscle stiffness, ligament tightness, and restricted range of motion. And it's very difficult to distinguish exactly what this is. It can sometimes present as a myofascial pain as well. And you would not find any great findings in terms of neurology, but you might find a lot of tenderness. And this sometimes patients can present with a vehicular accident, which is called as a whiplash associated injury, and which is also leads to a lot of facet pain. It's the chronic facet pains which present a lot to rehabilitation OPDs, and these can go on for years, weeks, years, and months together. And most of them have a local referral pattern. I'll show you the referral maps. And these are generally you can provoke them by rotation or by specific palpation to those facet joints. You can sometimes hear a little bit of crepitus as well. And some amount of investigations like imaging might be required, and you might have some opportunity to carry out an intervention to help your patients. So these are the referral patterns. You must know that these are not really completely discrete as it is. There are many overlaps. So generally, typically the upper, this is somewhere around the ear area, the back of the head and the ear area. And then the middle one, cervical spine is somewhere the neck and the shoulder. And the lower cervical spine is somewhere in the shoulder and the upper part of the back. But you can have some amount of overlaps as well in both the areas. A careful testing and imaging might be able to tell you where exactly this is originating from. So if you look at this study which they published, they said that to identify a painful cervical facet, you can examine the cervical's range of motion. You can do an extension rotation test because the facet joints are posterior, so you will get more pain with extension maneuvers rather than flexion maneuvers, which are more classically described as indicative of pain arising from the anterior parts like the disc. You can do some spinal examination where you palpate the articular pillars, and you can ask the patient whether they tell you whether there is some pain, and same thing with tenderness as well. If you look at radicular pain, obviously you will see a lot of uh, dermatomal signs. So you must be doing a testing which isolates each dermatome. Sometimes there are overlaps with the dermatome, so you must be a little careful. But you can very often pick up dermatomal signs if you do a contralateral. That is, if you do both appointments, if you do both. Side testing, you can pick up many times. Sometimes reflex testing can also give you, or careful muscle examination can also give you the patterns of where this might be originating from. Like I said, there are some provocative tests which are available. Two of them I have tried to describe over here. There are others as well. The Sperling's is the one which we most commonly do. It has the most, this has the best sensitivity specificity for this. So you just tilt the head to the affected side, and then you apply some axial pressure and try to extend it. The foramen actually narrows with this maneuver, and that can reproduce the patient's symptoms. The other is these traction tests which are used. So basically, what you do is you abduct the shoulder, and then you extend, laterally rotate it and extend the wrist and the fingers, and then you extend the elbow and ask the patient to bend towards the other side. And sometimes it can give rise to these patients. The traction tests are not as sensitive as the Sperling maneuver, but both of these are reasonable tests to perform to if you are suspecting that the patient has a radiculopathy and you want to find out. Like I said, there are other tests like the shoulder abduction. So the patient complains of relief when the patient abducts and keeps the shoulder up towards his head, or keeps both the hands up towards the head. There are Lermit sign, like I was describing, which indicates a myelopathic. This again, it has very poor sensitivity, but a lot of specificity. So if you have a patient with radicular pain, it's not necessary that all of it can come from the cervical spine. The radicular pain can be can be either compressive or non-compressive. And compressive, generally 90% of the compressive pains are due to a disc or a bony pathology, but non-compressive pains can be a lot of other things: cardiac pain, CRPS, nerve entrapment syndromes. So even like a nerve entrapment at the elbow or the wrist can give rise to pain which looks like a radicular pain, but it might not be a truly radicular pain. It might be some compressive neuropathy. We've had tarsal tunnel syndromes which present as radicular pain in the leg, and people image the lumbar spine, but they forget that other things are also possible. Malignancies, rotator cuff. So shoulders should be examined when you examine the cervical spine, because sometimes the shoulder can give rise to pain and you might mistake it from arising from the neck. Thoracic outlet syndrome is a very rare diagnosis. So I was saying that there are certain things that we should not be missing, even if you're not treating the patient properly or the patient doesn't get the, but these are the things that you should not be missing. If you miss it, there is a potential chance for serious damage or potential chance for full recovery of the patient. And the earlier that you are able to pick up, the better it is for your patient. So obviously, history of weight loss, history of smoking, history of previous cancer, more pain at rest, more pain at night. These are all constitutional symptoms. Patient is losing weight, patient is losing appetite, patient is having low grade fever. These are all signs of either an infective process or a malignant process. You need to investigate thoroughly to see where this is going. Neurological signs and symptoms always need to be investigated with an imaging study. So please don't send these patients off without imaging them. You can have vascular pains. Again, these are very, very uncommon, but and very difficult to catch as well. But if you do, it needs to be followed up and something needs to be done. Again, if you have a history of a patient with Down syndrome coming with a neck pain, you have to image the spine because atlantoaxial disruption, they have a lot of ligamentous instability. So ligamentous instability at the atlantoaxial joint can give rise to very devastating cervical spine outcomes. So this is a practical method for grading of neck pain, which we use in the OPD. It's very easy to do. So grade one is you have a patient with neck pain, but he has no major signs and ADL is fine. So here you can easily treat with some local medications and give some education and things like that, and patient should be okay. This grade two is where you have neck pain. There's no signs. It's so much of signs, but ADL is significantly affected. Here you might need to do more, maybe a block, maybe some amount of physical therapy, some exercise, some ergonomic modifications, those kind of things, and that should be okay. Neck pain with neurological signs needs to be investigated. Imaging plus minus electrodiagnostic tests absolutely necessary. Other factors to be ruled out. And neck pain with systemic disease, like we discussed in the previous slides, it needs to be chased vigorously. So these are some of the tools which are used for pain intensity. The numeric rating scale, everybody knows, it's easily done. For disability, it's the neck disability index. Again, it's not very easy. It's not very difficult to do. And you get a shorter forms of it also. Most of these are used for trials to report the outcomes. Catastrophizing, post-traumatic stress, cold hyperalgesia, these are not easily done, but some trials do look at that. If you are looking at some psychological studies, maybe you can look at all of these as well. But the first two are very commonly used. So if we get an MRI done, what do we see? Or even with an X-ray, what do we see? These are some of the findings that we would see. We would see narrowing sometimes. We would see some amount of ossification of the ligaments. You can see some spinal cord changes. You can see some osteophytes pressing. You can see sometimes discs herniating into the central canal, increase in the distance of the uh, C2 with the occiput, and those kind of ideas can give you some idea. Of course, an MRI will be warranted in these cases to give you a final diagnosis. You look at what happens when an MRI is done, the most common findings are in the C5, C6, and then in the C6, C7, this, and then both sides it reduces after that. So disc bulge, disc herniation, this degeneration, these are very, very common. You will also see some things like foraminal stenosis and facet joint changes and uncovertebral changes. So these are the most, why you see most changes in the C5, C6, and C6, C7 are because these are the most mobile segments of the spine. So degeneration happens most commonly in these areas. There are some studies which report now using SPECT. So what happens is if you plan an intervention and you're really not sure which area you want to intervene, sometimes it's done for surgeries, but you can do for non-surgical interventions as well. So if you find a picture like this where there is nothing which is being uptaken by the SPECT, then we don't know whether it's coming from the neck. You rely on your clinical findings. If you find where there is only one segment which is it, then this is probably the area. Now it can be the disc or it can be the facet you need to do. And if you see lots of areas like this, then you certainly will not subject this patient to any kind of surgery, because this is just too much of pain generators from many areas. There might be other factors also you need to go ahead, and this you can do some targeted interventions, but obviously you can't do intervention in the entire spine. So you can do some medial branch block and those kind of things, but surgical, so it's only in one or two levels. If it's there, you can do surgical. If you have negative or lots of uptake, then generally don't do too much of intervention. Just conservative management is good enough. So if you look at uh, uh, the studies which say that what are the pharmacological interventions which work, please don't use opiate analgesics for chronic pain. They can give rise to tolerance and dependence. So it's considered as not to be used except for very short and specific uses, maybe. But otherwise, it's a very controversial topic. Non-opiate analgesics are better. They have a short-term effect only on pain. So bear that in mind. It's not for longer term. Muscle relaxants can be used little bit more for intermediate term, and they help in pain, movement, and pressure tenderness, everything. The tricyclics and the gabapentinoids help patients sleep better, have a better mood, not so much with the pain. So if you have a patient who has pain and then says, I can't sleep, maybe you can add one of these agents. Local corticosteroid injections, yeah, do have a medium to long term effect on pain, range of motion, and ability to return back to work. Local anesthetic injections also have an effect on pain for a shorter term. Botulinum toxin has been used especially for myofascial pain and for some chronic painful conditions. Some short-term effects have been reported, but it's not really recommended for these conditions. So these are some of the interventions that are done for patients. So cervical epidural, so there are studies which do transforaminal cervical epidural. Be very careful about it. You need lots of training before you attempt these kind of procedures in the neck. The most deadly combination with this complication with this is that you can have a stroke or a vertebral artery uh, thrombosis or something like that, and that is not very good for the patient to have, neither a good complication for you to manage. So be careful about it, especially when using particulate steroids or you see a vascular uptake on the fluoroscopy. Interlaminar approach is more commonly used in cervical spine. It's easy to get trained on this and try and do it. It's generally done on a para median approach, and you just tilt the fluoroscopy from to a contralateral oblique angle, and you'll be able to go beyond the interlaminar line, and that's where you'll find the epidural space. Medial branch blocks, you can do a medial branch anesthetic plus steroid block, or you can do a radio frequency ablation. The target points are also very similar. You just take a true lateral view. The true lateral view is where every cervical vertebra stacks one on top of the other completely, so that you don't see the other. You don't see the other. It just looks like one line, and then you hit the center of this trapezoid, and that's where the medial branch lies. And for the upper ones, it's slightly upper, and even for the C7. But for the typical ones, it's all in the center. You can do a medial branch block as well for these. Like I said, for the upper ones, it's slightly more on the upper side, so the greater occipital. So these you can do even with ultrasound. You can see them very clearly. If you look at the physical modalities, what are the things that are recommended? TENS is recommended, short term only, no long term effects. There are some studies which say that magnetic transcranial stimulation, that's transcranial, it's not transcranial, it's magnetic done at that location, or direct stimulation can help some amount of pain relief, short term to intermediate term. Laser can help, acupuncture, needling can help, and intermittent cervical traction can help short term for pain and patient comfort. Continuous traction, heat, ultrasound therapy, and electrical stimulations have next to no effect. Excuse me. So they are not really recommended as physical modalities. The rest you can use. So this is one paper where they looked at mechanical neck pain and they tried to categorize the patient with mechanical neck pain with mobility deficits, mechanical neck pain with movement coordination deficits. That is what is uh, typically known as the whiplash syndrome. Then neck pain with headache overlay, cervicogenic neck pain, headache it's called as, and neck pain with radicular symptoms. Uh, so we have discussed all the findings. These are some of the things that you see with this. And if you look at what therapy is to be used, you can use all of these: manipulation, mobilization, ROM, strengthening exercises, and any kind of modalities. So there is this paper, which is this is a very recent paper. So what it says is, so it says multimodal therapy is recommended for patients with neck pain. So multimodal therapy means you combine a physical modality with an active exercise. So it's not passive exercise, no, not range of motion exercises, actually active exercises, and you act one of these. Generally, the duration is anywhere between 4 to 8 weeks, and when when they found a good, a moderate amount of improvement in pain, in neck disability index, and pressure pain threshold because of doing of all of this. So I think most of the people would be using a combination of this when they treat any kind of chronic cervical pain. Most of us are trained to use that. So that is what is recommended. Just doing modalities and sending the patient home is not a good idea. Doing both together might have a better option. This if you're opting for non-interventional treatment. Yeah, so cervical headache has diagnostic. Yeah, so it's basically you find you find amount of headache which has occurred along with a cervical lesion or with a cervical pain, something which has started in the neck, and then after that the patient has developed the headache, and then the headache gets better with this. So this is then it's named as cervicogenic headache. You find range of motion problems in the neck as well, and you can do some diagnostic blockade, and you can find that the headache becomes better. So you can name them as this. It's the same with occipital neuralgia as well. So these are the diagnostic. Like I said, ultrasound can be used. So the lesser occipital nerve between the sternocleidomastoid and the splenius. Splenius is the first muscle. The greater occipital nerve is between the obliquus capitis. So you just keep a probe at about C2 to C3, and then you turn it where the lateral end of the probe faces the mastoid process, and then you can mostly you'll be able to see these. So third occipital rate, all of this can be done. You can do a landmark guided injection as well if you have no recourse to doing cervical spine. If you don't have any recourse to ultrasound, again it's very simple. You just look at the occiput, and about very close to that, about maybe 1 or 2 finger breadths is the lesser occipital nerve, and slightly away from that is the greater occipital. So you'll be able to see. It's not very difficult. These are not very. There aren't too many vascular structures over here, so it's slightly safer to do without guidance as well. It's not as we see a lot of these patients post-spinal surgery syndromes. You see it in the lumbar spine, but sometimes you see it in the cervical spine as well. So what are the causes for post-spinal surgery syndrome? So sometimes, where you can see surgical causes where the patient has a pseudoarthrosis or a wrongly operated segment or an incomplete decompression done. These would require re-exploration. But most commonly, patients have a thing called as adjacent segment involvement. So they have decompressed one segment, but one segment above or below now starts developing symptoms, or with nerve root adherence. These don't happen very immediately after surgery. They happen a little while after that. So you need to examine the patient. You need to ask them with history whether like how soon after the surgery has it started. Is it similar to what it was happening, or has it changed now in character? And that will give you some clue as to what you're looking at. About 15 to 40% of patients after surgery tend to have it. Can be both axial, radicular, or either of them. and then you do an intervention depending upon what kind of pain you have. You can treat them with conservative measures as well, and they generally tend to do okay if you can find out what exactly is the issue with these patients. Posture. So coming to other to non-interventional ways of treating patients. Posture re-education helps very well. This you can do in your OPD. You just need to tell patients what are the things which are which lead to the maintenance of this pain, generation of this pain, and what is it that you need to do. So there's some basic mobility stretching exercises. There are lots of exercise apps which come these days, which are posture correction reminders. So basically they have exercises with reminders. So they'll tell the person that please, take a break or stop staring at the screen or whatever, or mind your neck and those kind of things. And there have been studies which say that if you combine exercises with these posture correction apps, they are generally as good as supervised exercises which they would do with a physical therapist. So if you don't have recourse to a physical therapist service, you can use these as well for something which doesn't have a lot of uh, findings, and most people would do well. For patients who have a lot of psychological overlay or tend to have lot of anxiety and those kind of things, we ask them to do these breathing exercises. They basically stimulate the vagus nerve, and you will see that it leads to reduction of anxiety and stress. And they tend to, again, these are also available in various apps, stress reduction apps and breathing apps that you see online, and you will be able to do them. They have guided this also. It's easy to do. Again, it's an OPD suggestion. You don't need to refer the patient anywhere. You can manage it yourself, easy. Proprioceptive training, it's basically to correct movement problems. So you do find patients who have a lot of forward stooping and incorrect neck ergonomics. You can use them. So it's basically a combination of head-eye coupling exercises, deep muscle activation, and isometric neutral spine exercises. Basically, you just sit in front of a screen and this and try to close your eyes and keep that laser pointed. So it does. So when you keep doing that and you keep maintain your spine neutral, you exercise all of this and you train this movement, and tends to have very good results. Again, this does not require a lot of supervision. Your OPD assistant will be able to do it if you have this kind of an apparatus set up in your place. We've seen a lot of text neck appearing in the news, in the popular media and newspapers and in the internet. So what they say is that as you keep bending your head forward more and more, you put more and more pressure on the spine, and then you get. So these are the angles which are. So you have this sagittal head angle, you have the forward head angle, and then you have the acromial or the protracted shoulder angle. So you get the chin downward tilted, head flexed or the neck flexed, and the shoulder hunched forward. Typically, people who do a lot of sitting jobs, computer jobs, mobile use, call centers, those kind of patients you would see with this kind of a posture, and it requires this posture correction. So not a lot of smartphone use, workplace ergonomics, some amount of strength training, some amount of chin tucks, so these kind of, again, you can give a handout to these patients. This does not require a lot of supervised exercises, and once they get an idea of what needs to be done, this is all that needs to be done. Most of the patients, generally they are younger people, so they generally tend to have a better outcome. So again, you will have people who will ask you, so is there any specific pillow that you recommend? There is one study which says that there's something called as a cervical pillow. So what they have said, this is not actually this, you get lots of such cervical pillows. What they have said is the pillow should have this much of height. It should have a contoured design and a cooling surface. So this generally tends to have that. It's slightly, the effect is very modest, but in case somebody asks you, this is the evidence behind it. So after doing this, patients don't improve. What are the causes for it? The most common two causes are kinesiophobia and central sensitization. So kinesiophobia means that the patient is just as just afraid to do exercises or to carry out the movement correction and the posture correction which is required, or they relapse back into that. So here you can use somewhat of your psychological techniques, your coping strategies. If you can do some CBT, or you have recourse to somebody who can do CBT, then that's fine. Or even simple patient education is good. With central sensitization, generally it's recommended to do all of this with somebody who's very well trained in it. But otherwise, patient education, stress management, you know, those kind of things can be done by anybody at any this. So if you have time and you can do it, it's easy to do. Not and most patients will tend to this. So finally, if you look at it, how do you treat these patients? So you have a patient with neck pain, you examine, you take a history, and then you see whether there is something which you can which flags off this red flag. And if you do, then that needs to be looked at, it needs to be chased. You shouldn't be leaving these patients. Once you find that there is no such this, and there is no imminent problem, there is no it's very non-specific, no findings, and not too much of trauma or nothing like that, that you don't need to do any imaging. You can just treat the patient according to how they present. So if it's acute, you can use a combination of medications plus minus some modalities. If it's chronic, then definitely medications is later down in the line. It's more to do with movement correction, exercise, active exercises, and some coping strategies. And if you have patients who have some amount of neurological findings, gait problems, then appropriate imaging and other diagnostic modalities are required. And if something turns up, either you can treat or you can refer to appropriate services and get them the care that they require. So I just want to conclude by saying that this is a very common condition. About 40% of people in urban areas can have neck pain at any year. And most of them are usually mechanical and not very serious, and can be easily treated with conservative measures, plus minus interventions as needed and as appropriately you are trained for. Um, if you have some condition which is serious and which you can pick up, that needs to be identified and appropriately managed depending upon what kind of diagnosis you reach. Thank you very much.
Thank you, Nitin, for an excellent presentation. How to it is. I hope this was very useful for all the PGs and those who are practicing physicians. How to approach a patient to a neck pain and how do we manage. Now the forum is open for discussion. Anyone who has some questions or comments, they can write in the chat box or they can raise their hand. We can take it with Nitin.
Hi, Nitin. Very
Hi,
good
sir.
talk. Can I have a question?
Sure, sir.
You spoke
Sure.
about the short-term and immediate-term effects of corticosteroid and local anesthetic agents. They were for a specific block, or they were only for trigger points?
No, they were a mixture of all of this. So it was not just trigger points. It was for even for epidural injections. It was for facet joint injections. For all of this, what they said was they tend to have anywhere between short term to long term effects. Typically how it is done in real life scenario is, obviously you have exhausted a lot of non-invasive measures, and you found that this is not helping the person. Or the other thing is, you find a target where you know that this is, so you see a nerve root, you see that it is impinged, you've seen that this is and it is a chronic condition. You can go ahead and perform an intervention. Generally, at least as a physiatrist, I have never done an intervention and told the patient that that is the end of your treatment. I take patients for intervention only if they first commit to me that they are going to follow through with a rehab plan as well. For patients who come only for interventions, I refer them to other colleagues of mine who are happy to do interventions and send them off. I don't do interventions on any patients unless they do rehab as well, if for chronic pain.
It's very, very good point actually. As we as physicians should understand this thing, that pain intervention is just one part of the overall process. Ergonomics and rehab is equally required before and after to complete the treatment. Very good.
Yes. So if you need to have credibility as a rehab physician, you need to put yourself out there as to what is different between you and any other pain physician who's trained in this. So this is one of the things we should be telling patients, that we use every possible modality to treat you. We just don't simply treat your pain and send you off. We try to see that we are correcting the factors which are responsible for maintenance of the pain. So that gives the patient the confidence to, to kind of trust in you that, okay, this guy is doing what actually needs to be done to fix my problem.
Good.
True. So I have one question that what in your practice of say only neck pain? Because when you are saying when we being rehab physicians, we are doing everything, and I'm sure if you are into pain, you have to look into the pain generator and come at a point where you need to do the interventions because it is important when not to do the interventions. With experience, you can gain that. And what is the most common condition which you come across for the neck pain?
Most of the, like a large portion of my patients are patients with uh, mechanical neck pain. It can be a facet pain, a discogenic, or a radicular pain, or a myofascial pain. These are the things which are very, very commonly referred to me. Again, very seldom do patients come to me simply as the first line. Most of them are referred by somebody. And what we find is that the treatment is done very casually. A whole list of medications are given which have no rationality between, in prescription, and then nothing else is told to the patient. Sometimes the patient is told ki jao or physiotherapy karo. Again, that is not written, it's not specified as to what needs to be done. Sometimes we see that the physical therapist has used 3 or 4 modalities on the same patient and then done no active exercises, and then the patient comes in, and when you say that, have you done all of this, they will say, yes, I have done it. Then you need to go into the details and ask exactly what have you done for this, and then you'll find that there are many patients where you have a trigger point which has been missed by everybody. Here it's very simple. You can do a trigger point injection, but again, like I said previously, I don't do a trigger point injection and send the patient off. I tell them, are you willing to come to me for a rehab program which consists of at least 5 sessions of stretching and active exercises? If you are willing to do that, I will do a trigger point injection for you. The trigger point injection will take away the pain for some time, so for till the effect of the corticosteroid and the local acts for 2 or 3 weeks, the patient will be fine. But if you leave the patient like that, or if the patient says that I'm going to do and then doesn't come back, you don't have any control in private practice. The patient will definitely after a month come back and say, अभी मुझे वापस वैसा ही पेन हो गया, मुझे एक और इंजेक्शन चाहिए. तब मैं, I for a fact I tell patients that you're doing this the wrong way, and it finally reflects on you. वो patient market में जाके ये बोलेगा कि I have gone to this doctor, he gave an injection but nothing happened. He will not say कि मुझे ये भी बोला गया था, ये भी बोला, मैंने कुछ भी नहीं किया उसमें से. But that happens. So
Yeah.
forgive me for people who are in government practice or in medical colleges. You will not understand this bit, but I've been doing private practice for more than 10 years now, so I'm just too attuned to this kind of practice. So these are the things that you need to. So lot of talking. Any patient comes to me, they spend half an hour. I have to spend to talk to them to make them understand what is important. And everything has to be drilled again and again into the patient before you can see reasonable effects. But I try to stick to this kind of treatment because that is what makes us different from the rest of the people in the market. There are very well trained pain physicians around who will do an excellent intervention, sometimes even better than you can do, but they will not address the rest of the problems. And if you look at your patients where you have addressed all the problems, they are more likely to do better in the longer term.
Absolutely. And I would like to add to this, it is not only we are in private practice, and I can see many of them, many of those who have joined, they are in government practice. So doesn't mean the patient has to be treated. The outcome has to be good. So we have to, when I was, because I have worked in government and private, we used to talk to half an hour to the government when I was in a government practice vis-a-vis in a private, because you have to talk to them. If your outcome is good, you are happy, the patient is happy. So this should be all the PGs, whether you are in government, whether you are doing DNB, whether you are doing MD, please have the practice that talk to your patient, tell them what you are going to do, how educate the patient, because first thing is assessment and education. The first time when they come to you, if you say intervention. So I was coming to the next question: how many patients have, do you see in your OPD, or you think that, okay, let me do an intervention at the first go? So what are the percentage which require actually the interventions?
Hardly ever, ma'am. Hardly ever. Hardly ever. Patients require intervention at the first this. In fact, if you do it well, if you can do non-intervention pain management well, there are very few instances where you actually need to do an intervention. If for the cervical spine, hardly ever. For the lumbar spine, sometimes. For the shoulder, very often. Sometimes for headaches, I do first time intervention. But for cervical spine, I cannot, I mean, putting my mind back, I cannot think of a case where I have done an intervention right at the first go.
Absolutely. So the most common cause is mechanical, or nowadays after this, the text neck syndrome, the myofascial pains, they are more common, which are mimicking the facetal or the radicular pain. So these have to be dealt with, and who better than a rehab physician can do that? And they keep on roaming here and there. And for us, because for you and me, they don't come as a first time, they come referred. And they are in a dilemma, what is the diagnosis? And even the patient, they say that family thinks that they take them to a psychiatrist, and then they think that there's something wrong in their mind, everything is functional. But no, it is not functional. When you give them a diagnosis, they are very happy. Okay, it is a myofascial pain, and then you can start your interventions. Doesn't mean in the form of only injections, but yes, conservative followed by if not getting better, then interventions. Wait for some time. That is the main thing. And then they come back, doesn't mean. That is what, when you have in your practice, government or private, if they come to you, you have to talk to them that what we require from you is two things. The pain should be reduced and it should not come back. Reduction is whatever we are doing. If you are going for an intervention, if not come back, is by the proper rehab, whether it is ergonomics, exercises, strengthening, endurance, whatever it is. So it is very important that we emphasize on the rehab part of it, because we know the pain generator, and then emphasize on the what after injections if they are referred as in a tertiary care center. So, and interventions, they are only the 10% of all. Not that anyone who comes try to think, okay, which nerve should I block? Where should I give the injections? And yes, in neck, the transforaminal or cervical periradicular pains with ultrasound, they have become very less, but they are very easily to perform with less of side effects. And even the ultrasound, with the ultrasound, you can change into the medial branch block. Radio frequency ablations, they are very, very, very rarely done. So let's take some question. Regular use of SSNB for trigger point is beneficial? I don't think so. The SSNB for trigger point in anywhere is essential, is not beneficial, because you have to know that it is for the shoulder pain. If there's a rotator cuff tendinopathy, that is where the suprascapular nerve block will be helpful rather than the use of trigger point injection. Then we have a question that, can you please highlight the use of algorithm in busy OPD to narrow down the diagnosis of the cause of the pain? Nitin. So what is the algorithm if a patient comes to you, okay, let's do this movements, and then we know this is a facet. So what is this?
Yeah, so the first thing that I want to tell you is that sorry, I think I have lost this. One second. So I'm sorry. Yeah, okay. Yeah. So if a patient with neck pain comes to me, the first thing that I need to know is it truly a neck pain, or is it a pain coming from any of the other mimics? That's number one. Second, if I need to, if I know that this is truly a neck pain, I need to rule out whether there is any specific treatable cause that I'm missing. So I need to ask a whole lot of negative questions. So this is how I go. So I ask a whole lot of negative questions. Do you have fever? Do you have weight loss? Do you have the malignancy? Those kind of things. If I find that those are all normal, it has been ruled out by a previous imaging and this, then the third thing I need to find out is which is the pain generator. So the pain generator here in this case can be either. So then you need to know whether it's an axial pain or a radicular pain. That gives you an idea. Then you need to know what is the severity. What are you looking at? Are you looking at a chronic moderate intensity pain, or an acute very high intensity pain, or a chronic very high intensity pain? The fourth, you need to know what's the mood of the patient. What does he feel like? You've been seeing so many doctors. What do you feel like? You ask these questions. They're like, I'm depressed. My family thinks that I'm just faking it. I'm taking a whole day, lot of days off work. I'm stressed. I'm this. You can see that. So that needs to be addressed. Then you can go do a focused examination that will tell you. So you have articular pillars. You can find some amount of, you can stress the muscle groups which are doing those. So you'll the muscle. You can palpate for trigger points or tender points. You can look at the of the occiput to see if you have some kind of radiation over there, and then you can do some of these nerve tension tests to see whether you're looking at a radiculopathy. And finally I do a focused neurological examination just to see that I'm not missing something. You can have overlap syndromes, so you do sometimes see patients who have both together. So that is when you can see that. And then based on that, so like I'm assuming that I've done nothing, no imaging, nothing, and then based on that, then I can take a call whether I need to do an imaging, what I need to do next, and what is the medication that I need to. So if I see a patient with a lot of neuropathic symptoms, I need to add some neuropathic pain medications and warn the patient that this is not going to show effects immediately. It will take some time, and probably add some medication to us to address the chronic pain. Muscle relaxants I tend to add only if I find some restriction in the joint, in the range of movement. If there is no restriction in the range of movement, if the range of motion is free, I generally don't add any muscle relaxants. If I find no findings at all, no this, and the patient complains only of pain, I actually give the patient an offer that are you willing to do these exercises and not take any medications at all, and you will still get better. And if the patient says, I don't want any medicine, or if he agrees to that, I generally sometimes tell patients that this can be treated without any medicine. Many times the patients look at me as if ये कौन सा डॉक्टर है जो बोल रहा है कि don't take medicines at all. But if you make the person understand your rationale, why you're doing it, why this has occurred, and what is it that many times patients with IT professionals come to me, and very seldom do I give them medicine. I tell them also, if I give you medicine, you will sleep at work, or you'll find it difficult to drive. I can manage this easily with movement correction exercises and without any medication. In 2 weeks, you should be fine. And some ergonomic modification. And they are like, many patients agree to it. They're like, they're pleasantly surprised that a doctor is giving them an option of managing this without any medication. So yeah,
We'll be
so this is
happy.
how I would, yeah. So this is how I generally go about, so that I see most important thing is not to miss anything, and
Yes.
to not to miss something which is very eminently treatable. You can change somebody's life by even by being a very good diagnostician. Like I told you the case at the beginning. In that case, because I picked the neurological finding fast, because I referred fast, because the surgery was done fast, his spine was saved. So there, that is a positive impact that you have made on somebody, which is why possibly all of us become doctors in the first place.
Absolutely, absolutely. Very rightly said that finding out what are the pain generators at, as you had said in the first slide or first few slides, the nerve, muscle, ligament, joint, disc, and then not missing any of the neurological red flags. That is how we can go for the diagnosis. The last question is any role of posture correctors for routine use?
Yes. Oh, yes. Almost invariably, everybody have. I mean, almost all your patients will have posture issues. I projected one this where they were measuring angles and they were seeing that this. So there aren't very good studies which say what is normal and what is abnormal. But if you see the patient, you observe the patient from the side, you will be able to see, or you ask them, or you demonstrate those postures to them. So sometimes I show, do you sit like this? Say, yeah. The person next to will say, oh yeah, my wife does this all the time. And here you don't have to do anything if you've already got it, and it's a eureka moment for the patient also, because they understand, okay, this is what you need to do. I get patients on online consultations also, and then I ask them this and they are like, oh yeah, I tend to do that when I drive. And the answer is very simple: you need to change that. You need to find, some there's kinesthetic reminders to see that you don't get into that posture. And most of the times that the pain goes away in some time. It is you have to again tell the patient the one more thing, that this is not a permanent fix. It's not that this is going to take it away completely and you will never have it. Some amount of sensitization is there. So if you keep doing that, or if you come back into this, or if you develop a stressor again in your life, there is always a chance that that pain might come back again. So this is another thing we tell, that you should learn to accept some good and bad days as well, especially if you keep doing that. But on what we are trying to do is on the whole change it. So if you have like 50 bad days, we want to reduce it to, say, for example, 10 bad days. I think that is an acceptable thing. So in chronic pain, this kind of mentality is necessary for you also to develop, and for you to communicate to your patients as well, that chronic pain is not something which completely goes away and never comes back. There can be sometimes relapses. You need to find out what is the relapse and then treat that relapse accordingly.
Very rightly said. Yes, there is a role of correction of the posture, but using the posture correction belts, I don't think so, because you are weakening the muscles. So with that, we have, so with that, we have overshooted the time, and thank you so much for a very interesting session. I think all the PGs and all of us have learned something. We have shared our experiences. Asmita, can we have the next session, the slide of the next session? So with this, we invite you to the next session, which is the session 8 on 8th of January, which is the evaluation and management of spastic diplegia. Very interesting topic by Dr. Vivek Chawate. And thank you so much for everyone for joining us today. Thank you, Nitin. Thank you, Dr. Abhishek. And
thank you, ma'am.
Amit
Thank
could
you,
not
sir.
join us, but thank you so much.
And thank you to everybody for attending this.
Thank you.
Have a nice day. Bye.
Bye bye.
Bye.